We've already started, and I don't know how the technology works. We do not have to call the roll because we don't need to have a quorum. We can just begin. Thank you all for coming. Let me explain a bit about why we're here and what I hope to accomplish. I believe the legislature is very likely to enact at some point some legislation concerning medical marijuana. I think it would be well for us to talk about what that might look like. There are a number of issues, and at some point, if we're going to pass something, we're going to have a bill that the Senate will pass, the House will pass, and the governor will sign. And so the sooner we all start talking about the provisions that are before us and the options that we have, the better. I would simply say by way of introduction that from my perspective, the first question we should be asking ourselves is, to what extent should marijuana be available in Mississippi and under what circumstances? As a policy matter, what should that look like? And there are reasonable people who believe marijuana should be prohibited. There are reasonable people who believe recreational marijuana should be available much the same way as alcohol is available, and every perspective on that spectrum. But wherever you come down on that, and wherever the consensus is, and whatever we think about the availability of marijuana, it seems to me that's the first question. Growing marijuana, taxing marijuana, all of that stuff is a secondary matter. The most important issue and the initial question is, what is in the best interest of the public in terms of the laws regarding availability of marijuana? So that's sort of what I would like for us to talk about. We have with us, of course, Senator Blackwell, who, as you all know, has spent more time on this issue than I think any of the rest of us. He certainly spent more time on it than I have. He certainly knows more about it than I do. And so I intend to recognize Senator Blackman repeatedly during this process, whether he wants to be recognized or not. But do you want to say anything now? Or okay, the first person that we have to testify is Ken Newberger with the Mississippi Medical Marijuana Association. Mr. Newberger, come on up. If you're more comfortable from the podium, I think there's some chance you might be heard better from the podium. All I can tell you is we used to have, back when I was first elected, this before you were born, there was a sound system in this room that worked just fine. And over the years, we've had more and more and more improvements to our sound system, and now this is what we have. But I do believe that given the current sound system, you can be most heard from there. But thank you for coming. What I'd like for you to do is sort of explain to us what's in the referendum. And I've got the text here before us of the constitutional amendment, how that came about, what policy decisions you made, and just generally an overview of where that stands. So basically just proceed however you'd like to, and then when you finish, I think we may have some questions.
Thank you. Thank you, senators, for being here and hearing about this important issue. Thank you, Senators Bryan and Blackwell for taking such a big interest in this for the past 6 months. I am the executive director for Mississippi's Medical Marijuana Association. Prior to that, I was the campaign manager for Initiative 65. So I'm going to talk a little bit about how that came about and why it was important to us. So in 2018, many people who wanted to see medical marijuana come to fruition for patients, the enumerated conditions in the initiative were the ones that we selected after looking through, at the time, there were 31 states with medical marijuana programs. And we thought that overall, those were the ones that made the most sense after we had talked to several Mississippi doctors and several doctors in other states who had experience with medical marijuana. As the drafting process went on, we included different doctors from MSMA, people at the health department at the time, and just industry experts from outside of Mississippi to tell us about what it was like in their states drafting a program. The end result of Initiative 65 was the best thing we could come up with in 2018. Obviously, 3 years have passed. More states have passed medical marijuana programs. More have had problems with their medical marijuana programs that we didn't foresee. So there are some major gaps that I think a lot of you have pointed out in the past, and a lot of people in the state have pointed out that need to be remedied with any program that happens moving forward. What Initiative 65 really did from a basic procedural standpoint is it allowed patients with certain debilitating conditions to go and see a doctor, get certified that that condition is one that could be benefited by medical marijuana, then take that certification to the Department of Health and start receiving medical marijuana from licensed business entities within the state. That is what I think really matters, that basic concept. There are a lot of other problems that people pointed out kind of bureaucratically that I think we need to fix. But to your question, Senator, the main thing is a patient could go see a doctor and get certified to have medical marijuana. Since Initiative 65 passed, a lot of people were very excited to see the program come to fruition. And I think the main things that they wanted to see are the 4 principles that we really stand on at 3MA, which are number 1, broad patient access with the number of conditions that existed in Initiative 65, with access to all forms of medical marijuana that could benefit them. Secondly, letting doctors certify patients for medical marijuana, that it's in their hands and their decision-making. And then also keeping it a very free market system so that small businesses in Mississippi can open and compete. And finally, maintaining that the self-sustaining nature of Initiative 65, where everything was going to be collected through fees and taxes that would fund the program itself and not be an extra burden to the taxpayers. There are a few other things that I think are very important, but those are the main 4 points. Everything else that people have kind of raised, I think that the Mississippi Municipal League really talked a lot about the prescriptive zoning restrictions that were in Initiative 65. I think that's something that we should be revisiting. I think that the health department over the past 6 months has really identified some of the things about what's in their wheelhouse and what should be maybe in other areas of the state that can keep the program running efficiently. And I think that needs to be considered. But again, the main 4 points of keeping it a free market system that brings patients their medicine through interacting with doctors and keeping it self-sustaining are things that we believe in. That's kind of the overview of 65 and where its advocates are as of now. And I'd like to answer as many questions as you're going to ask.
If someone were to say to you, this looks like what is being proposed looks like an awful lot like recreational marijuana being available under the guise of medical marijuana. And looking at the experience of other states, it seems to me that there is a huge demand for marijuana, and we're talking about large quantities. Do you think that's a valid criticism, or do you take the position if a doctor prescribes it, that's the end of it? And if a doctor is overprescribing, you have the same, I'm told the word prescribe is wrong, but whatever, that you have the same remedies against a doctor who is overprescribing as you would for a doctor overprescribing opioids or anything like that. What's your reaction to that sort of criticism?
The latter part of what you said is my reaction, which is as doctors are certifying, the same oversights that are for doctors who might be overprescribing opioids should be there for people who overprescribe medical marijuana.
But other than that, that's the response to the overprescribing.
Yeah, I did not see that in a system where physicians are the certifying people for medical marijuana. I don't see that as a recreational system.
Okay. Senator Blackman, you've spent some time on this. I'll recognize you at this point.
Thank you, Mr. Chairman. Thank you, Mr. Newberg. Is this thing working? Okay, thank you. You talked about all forms of marijuana being available, and I agree. Hello. Boy, I've got. You talked about all forms of being available, and I agree with that. I think one of the issues I know I faced when we were passing our bills in the Senate was the smoking component, and I even referenced that on the gallows show, and I think my words were, I think it's going to be a hard sell, but we were able to overcome it 3 times in the Senate to get it passed. Initiative 65 seemed to primarily focus on smoking. I know there was other components, but they were just barely briefly mentioned. Is there any reason you guys limited comment or explanation on edibles and topicals?
Yeah, 2 reasons. One, edibles and topicals are kind of industry defined. So as the industry would develop through the regulations, that's where that would be handled. Because of how much law there is restricting smoking in Mississippi statutory code, we had to address it a lot in the actual initiative. So that's why it's so prominently focused in the initiative. It's more of to overwrite the laws that would have otherwise been making patients criminals.
So there are standards there already there for edibles and topicals and things of that nature within the industry?
Yes. And just so everyone knows, with me today, I have Angie Calhoun, who has been a major patient advocate for the entirety of Initiative 65, who can talk a lot about how patients would be receiving different medications. So if you do need someone to give a little bit more in depth on that, she can. And then I also have Clint Patterson, who's the CEO of the Mockingbird Group. They have a lot of industry knowledge from multiple states who can talk about industry from an industry perspective to answer as well.
From other states that have allowed smoking, is there a limitation? Have they put limitations? Because personally, 5 ounces seems like in a month seems like an awful lot of marijuana.
They have and they haven't in different states. Some states it's pretty exorbitant, saying as much as 20 ounces a month. And some states it's pretty consistent with ours. That we looked mostly at Arizona and Florida when we were looking at the amount that could be given every 2 weeks. And that's where we came from, as well as from Ole Miss's program, which permitted, I believe, 2.5 as well.
As far as the growing, I know the Department of Health did a great job with their coming out with their rules and regs. Would you agree with that?
Yes, I think that they did a really great job. There are a few things that we thought could have been tweaked, but overall, they did a fantastic job.
As I read through, they talk about facility and where this product would be grown. Mm-hmm. To me, that's an indoor facility. Would that be consistent with your thoughts as far as growing or cultivating?
I think facility can be anything from indoor, hybrid, and outdoor. However, the security standards that are surrounding a facility need to be consistent. So if an outdoor facility needs to have higher standards so they can meet the same as an indoor facility, I think that's very important. And I think that was what the Department of Health was driving at. And I'm not going to speak for them. I'm going to let them talk about why they went with that language. But I believe that's what it was.
Is there, from that standpoint, if you allow it to be grown outdoors, is there any consideration or concern about contaminants, pesticides, herbicides, fungus, quality? Because the heat's going to change things. Weather's going to change the product.
Yes, and I think you're driving at, if I may, the fact that marijuana is a very absorbing plant, that it takes pesticides and very different elements in the outdoors negatively and could be contaminated very quickly. And I think having a rigorous lab testing program where you make sure that nothing gets to a patient without having sufficient lab testing to make sure it's safe, I think that's where that's remedied.
Did you mentioned earlier there's some things that you need to fix or you would fix going retroactively? What are some of those items that
Well, I
address?
mentioned, loosening the zoning as one of them. I think that it was a little too prescriptive in Initiative 65. I also think that putting everything under the umbrella of the health department was a short-sighted mistake. The purpose of that was to make sure that everything had one decision maker, so that way it didn't get gummed up in bureaucracy. But I think that the flip side of that is that we were asking our health department to do things that were very, very far out of their expertise, and helping them with other departments that would be more in their wheelhouse is something that we need to fix.
Right. Sorry, you mentioned something that I wanted to go back to it, but I'll come back to that. Have you read or did you take a look at House Bill 119? It was the last bill that the Senate passed that had language in for medical cannabis.
Yes, I did.
Why didn't that bill, did you not like? Or
So there were two major things about that bill that we opposed as 3MA. Number one, kind of the elephant in the room is Initiative 65 itself. We didn't think that there needed to be any extra program as a fail-safe. We thought that the vote happened and would stand, and that was it. The second thing, while I do think that House Bill 119 was very good from a patient perspective, it gave great protections to patients. It gave them great access to medical marijuana. There were certain things about it from a business perspective that we didn't agree with. The one that comes to mind immediately is demanding that every county has one dispensary. I would foresee that happening in a way that the first dispensary to open up gets all the business, and then anybody else who opens up later can't compete because they already have all the patients there. So those kinds of things were the things that we had issues with. And I think with the open timeline of getting together legislation to make a program, I think we can all work together to make that a better system.
you've referenced that a couple of times. I think on the radio, you want to work with the legislature.
Yes, please.
Are you working with anybody now?
I'm starting to sit down with different senators and representatives, but it's a slow process as everybody is scattered across the state.
Have you reached out to me?
I've been trying to go through the right channels to not upset, quite frankly, I wanted to make sure there was no bad blood between us before we started sitting down. I would love to sit down with you.
No, there's no bad blood.
Thank you.
And I'd be happy to sit down with you. Chairman Bryan said, and we were trying to get information. We want to do this right.
Mhm.
At this stage, we'll be the 38th state to have a medical marijuana bill. I think we have an opportunity to lead the nation in terms of coming up with something good. There recently, Alabama has passed their bill, and there's some things in it that are to me attractive, and there's some things that were not appealing. One of the things I did like was their protection of employers. I don't know if you had a chance to read the bill, and if you did, could you opine on your feelings there?
I've read some of the bill. I haven't spent as much time with it as I would have liked. I've been focused more on anything that's passed in Mississippi. So your bill, our initiative. But the protections that we had in Initiative 65 for employers, I think they're great. I'm not sure if we need to look at Alabama's bill. I haven't read that specific portion, but protecting employers from and anything they want to do regarding their employees and their patrons, I think is very important.
Yeah, their bill process is a little different from ours. They get into a lengthy explanation of why they're doing what they're doing within the text, but I do think having something to protect employers would be good. On the zoning restrictions, are you familiar with our alcohol laws?
Yes.
We have restrictions regarding the location of a package store.
Yes.
It has to be 1,500 feet away from church or school.
I believe that varies from county to county. I thought.
It does not.
Okay.
The state sets that. But so it is 1,500 feet. Would there be, what's your thoughts if we were to have that kind of restriction between schools and churches?
Well, I think that 500 was a good starting point. I'm not sure 1,500 is appropriate if we're throwing numbers out. I think that's something that we should be discussing with municipalities about what they think, because it's a medical program and not a recreational program like alcohol is. I think it's a more complicated issue.
And as regarding zoning, would you favor an opt-out for municipalities or counties? If there was a referendum to allow the municipality or city to have a referendum if they wanted to opt out?
I would not support a direct opt-out system just because we can't have patients that are already crippled with some kind of debilitating disease driving 3 counties over to get their medicine.
But it'd be up to those people to vote in those areas. So you're against the people voting?
Absolutely not. If you're asking that the people would vote to opt out, that's a different thing.
That's what I'm asking, for them to have a referendum. And it works much the same way as it does currently with alcohol laws.
Okay.
The municipality or city would have to have a referendum and vote, yes, we want, in alcohol's case, we want to be wet versus remaining dry.
I think that's something we should talk about. I prefer where the default is that patients have access to medicine and they need to discuss what that looks like if they don't. But I just blanket opt out for municipalities to just choose themselves. We're against that.
And I think you'd favor us, if the governor were to call us into special session for this, you'd favor that decision so for us to get together, the legislature, to get a bill passed quickly.
Yes.
All right. Thank you. Thank you, Mr. Chairman.
Do other members of the committee have questions? Senator Wiggins.
Thank you. Thank you, Mr. Chairman. And I want to say to you, Mr. Chairman, thank you for calling this meeting, especially at this time, because I think it's very important. And I, like many, probably all my colleagues, have heard from constituents after the Supreme Court's decision. I have a lot of questions, but I'm going to keep it as short. Thank you. And then in the amount of time I have. So couple questions. If I understand what you're saying based on what Senator Blackwell was saying, then you do agree that there are things that need to be addressed and changed in Initiative 65, i.e. the zoning for one. Is that right?
That's correct.
Okay, because I just want to be clear, because since the Supreme Court's decision, I have received comments that like the legislature should only do what Initiative 65 says. And I appreciate you saying that. And one of the things that I've pointed out is the zoning issue. And have you read the Supreme Court opinion, which I assume you have?
Yes.
And so the zoning issue is what gave the city of Madison standing to continue the lawsuit or to continue their challenge. Is that right?
I believe so. I was mostly focused on the individual capacity of just examining the law that the mayor of Madison had.
Yeah, it was the second issue that was challenged, and it said that yes, the city of Madison had jurisdiction or had standing, and therefore the case couldn't be thrown out because of the zoning issue, because the zoning was going to lead to could be bad outcomes in the city. And so to Senator Blackwell's question, zoning is a very, very local issue. Are you familiar with that?
Yes, I live in Madison.
Okay, you live in Madison. Oh, okay. So then you're okay. So sorry, that's funny. Okay, so that's one issue. And so there's other issues that need to be addressed by the legislature. What are a couple of the other issues that you see now that we've gone through this?
Well, like I said, I think putting everything under the Department of Health rather than including explicitly the Department of Revenue and parts of the Department of Agriculture need to be addressed. I also think that the fees for businesses to become licensed could probably sustain the program itself, and any excess fees or taxes on top of that could maybe go to the general fund in some kind of way, and that could be addressed as well.
And speaking of that, one of the things that I've heard from constituents since I guess all this has been brought up as a result of the decision is about the taxing of it. And I can't tell you how many people have told me that they didn't realize that the taxes didn't go into the general fund. Now, I'm not up here saying that I'm here to make a tax grab. What I'm saying is that people have told me that, and they question, and I've had people tell me it should go into the general fund to address these issues. If I understood, you said you want it to be self-contained, or that, and so you're against it going into the general fund to fund things just like any other program that we have.
No, I think the priority needs to be that it becomes self-sufficient, and then excess can go in ways that it solves other problems.
So you don't have an objection if that's the general fund, or if the legislature says it should go to the Medicaid program or something like that,
Correct.
as long as it's self-sustaining,
Right.
which I think that's smart. Okay. And so then I'm just going to bring up this question, because you're coming from the medical side of this. Totally understand. With the overwhelming support and the overwhelming vote, my question is, why don't we just go to recreational? I mean, from the criminal justice side of this, we've lowered the penalties on marijuana. There's been other states, I think New York just went recreational. And if we go recreational, then we don't have to do it as, we just regulate it like we do alcohol or something. And, you know, we don't, and correct me, because I think what I've heard in other states is that they've gone to medical and then it ended up being recreational. So why don't we just jump to recreational?
I can't answer that question. I'm just here to talk about how a medical program comes to fruition. If you want to talk about an adult use program, that's just not our wheelhouse.
But would it be incorrect to say that many of the supporters would support an adult use, as you're calling it, an adult use program?
I think there are a lot of people in this state that do support an adult use program, but I don't think it's nearly as many people who just want a medical program.
Okay. Thank you, Mr. Chairman.
Senator Blackman.
Thank you, Mr. Chairman. Mr. Newberger, is alcohol prescribed by physicians as a form of treatment?
I don't believe so. I'm not sure.
And so if it is, and this medical marijuana, it would be prescribed by physicians for treatment of certain conditions, correct?
They would be certified, yes.
So therefore, would it make sense for us to treat medical marijuana as a local option where someone could have a referendum to vote whether they want their citizens to utilize medical marijuana?
I don't think so. I think that because it's a different issue, that it's a medical program exclusively. I don't necessarily think so. The system that Senator Blackwell proposed, I just haven't really thought about it. The only thing I really have thought about is if there is a kind of a top-down complete opt-out by a municipality, I'm opposed to that. But as far as what you're describing, this is really the first time I've been talking about it.
Thank you. Thank you, Mr. Chairman.
Senator Horn.
Thank you, Mr. Chair. Mr. Newberger, given the fact that 75% of voters voted to allow the availability of medical marijuana in Mississippi, and in the initiative, there was a heavy prioritization of a free market system. And you mentioned that the four pillars of what you all are still committed to are broad patient access, letting doctors certify its use, an open free market system, and making it financially self-supporting. So do you advocate limiting licenses for the growing, selling, processing, and dispensing of medical marijuana?
Not at all.
Would you elaborate on why you think that's important?
So we've seen in states especially in Arkansas and in Florida, that when you limit licenses, you see a lot of people, one, competing for those licenses, and then things get gummed up through either legal action or people fighting back and forth and infighting with people who are starting businesses. And that stops patients from actually having access because they're more concerned about setting up their own businesses than actually getting patients their medicine. And so when you have a free market system that has reasonable standards for what a business could be and how they get certified, the end result is once those thresholds are met, they are respectable businesses that can open and deliver medicine to those patients.
Do you favor a three-tier system similar to what we do with the malt beverage industry? For example, if you own a retail store, you can't be a distributor. If you're a distributor, you can't brew beer, etc. Do you favor separating the growing, processing, and dispensing of medical marijuana?
Not the growing, processing, and dispensing. The only thing that we believe should be separate is the testing. That if you have considerable interest in a testing lab, you can't also grow, dispense, or manufacture. Essentially, you can't test your own product and tell people that it's good. That's just too much of a conflict of interest. But as far as owning a dispensary, a grow facility, and a manufacturing facility, that is something that we think should be allowed.
So what are some of the advantages of not having that limitation of a three-tier system?
Well, just from a supply chain system, they'd be great. It might be best if, Clint, do you want to take a stab at why one would have all three of a grow, a dispensary, and a manufacturing? Is that all right?
I think we're getting a little bit short on time, and when Senator Horn finishes, I was about to recognize Senator Blackwell and then move on to the next speaker. So I'm in a difficult position of trying to have a full and open discussion, but at the same time, we have some time limits. So
I have one final question.
Maybe we could move on to another question.
We'll get together.
Senator Horn.
I've got one final question. Do you advocate the prohibition of past felons who were convicted for the sale or possession of marijuana in the past to be prohibited from being able to grow, process, or dispense medical marijuana?
Looking at felonies as a whole and having a reasonable sunset on those felonies, I believe the Department of Health had, I think it was 5 or 10 years of a disqualifying felony. After a certain period of time, you won't be prohibited. I think that's a good way to go about it.
Thank you, Mr. Chairman.
Senator Hobson.
Thank you, Mr. Chairman. I do have only one question, and I know there's been some discussion about this being a medical marijuana program, and I think I know the answer to this. I've heard it at least on the streets, but why, if it's medical, is it not to be sold in pharmacies that are already set up, as opposed to creating a new entity, a dispensary, to regulate this? Thank you.
Unfortunately, because it's still a Schedule I drug, and it's looking like it will get descheduled within the next year or two, but because it still is, it cannot be put through a normal pharmacy the same way that other drugs would be. And so it must be its own standalone because of the way it's federally regulated, and nothing that state law can do because of federalism, can usurp that.
Senator Blackwell.
Thank you, Mr. Chairman. Just three quick things. You do favor vertical integration, then, with the exception of testing in a program. Is that correct?
I think it should be permitted. Yes.
All right. And then did you happen to take a look at the Senate bill, the people who could write certificates?
Oh, yes, that it's essentially anybody with prescribing authority.
Yes. Your thoughts on that?
I think that's a really great decision. You mentioned the kind of the political challenges of smoking and getting that through. And I know you got the larger prescribing authority through as well 3 times. And I thank you for that. I am in favor of that. It's just not one of the main pillars that we are out here pummeling.
I understand. And the last thing, we also increased the number of diseases or conditions that people could qualify for a certificate. Were you in favor of those as well?
Yes, like I said, I thought that the bill did a really, really good job of protecting patients. And so I thoroughly agree that that's a good way to go.
Thank you. Mr. Newberger, we appreciate very much your coming to visit with us. If you have any material you would like to have made available, we're going to post whatever documents we have on a website, so they'll be available. So if you have anything you want us to post, let us know. Thank you again for coming.
Thank you.
Members of the committee, it was several years ago that we were having a rather large event in Amory. It was attended by a number of Hollywood stars who were performing, and Governor Barber happened to be there. And I noticed that when it came time for Governor Barber to come on the stage, they were careful to introduce him and a Hollywood star at the same time, so that there would be one round of applause, and it would be impossible to determine what applause was for what individual. With that in mind, we have our next speaker, Dr. Thomas Dobbs, and we're happy to have with us today both the Speaker of the House and the Lieutenant Governor, the three of them. The three of you can decide among yourselves which of you were playing the roles of Governor Barber and which of you were playing the roles of the Hollywood star. Dr. Dobbs, we appreciate your coming to visit with us.
Good afternoon, Senators. Thank you all for having me again. It's good to see you all again. Seems like it hadn't been that long. I've got some information to share with you guys. We have some handouts, and Chairman, is it time for me to go on? Or you ready for me, sir? You ready for me?
Oh, yes, sir.
Yes, sir. Okay, great. So Senator Bryan asked me to go into a few things, talk about the sort of like the proven sort of medical uses and our knowledge about marijuana, what a medical program looks like based on other states and what the science shows, and talk a little bit about what we learned along the way as we were putting together the regulations. And I've got some information that I'll share with you guys. I'm going to go really quickly because I know you guys are used to processing information fast and time is precious. So I'll start off with talking about what products are already approved by the FDA for medical conditions. These are cannabis-derived products. We have 2 synthetic THC products that are approved for anorexia associated with weight loss in patients with AIDS, nausea and vomiting associated with chemotherapy who have failed to respond to conventional treatments. These are Marinol and Syndrose. And you can see the maximum daily consumption of 20 milligrams and 16.8 milligrams daily. We also have CBD products, Epidiolex, which is approved for childhood seizures associated with these rare syndromes. So there are some products out there that I think we can serve as a foundation to begin our medical conversation about what medical products look like. As far as like what evidence is available about the utility of cannabis products for medical purposes, there is some limited evidence that cannabis may alleviate neuropathic pain in some patients. There is insufficient evidence to say that it's generally effective for pain syndromes, but I will admit that it is entirely understudied. Kind of like with any medical situation, we need to have clinical trials to understand what it's really useful for. And so there is a deficiency in clinical trials that will have to be clear about. There is another cannabis product that is called Sativex. I believe I'm pronouncing it correctly. It's about even like 50-50 CBD and THC. And it's available, I think, in Canada and some other countries. And it has been shown to have some short-term improvements in pain related to rheumatoid arthritis. And I do believe they use it. It's approved for spasticity, especially associated with multiple sclerosis outside the United States. So we do have a foundation for some cannabis products that have been evaluated. But I do want to reiterate that there are potential harms. As we look into this, I think we need to think about it in the context of it's not a panacea. There are downsides to everything. And as we think about the safety of our most vulnerable Mississippians, we need to consider the potential downsides, especially if we consider teens, youth, pregnant women. We do know that there is cannabis dependence. It's about 9 to 10% for users, and it's higher for people who are adolescents. There is a dependent syndrome. We do know that kids who start using marijuana at a young age, it will lower their IQ. That's all. We don't want to have lower IQ kids in Mississippi, right? So about a 7-point differential for kids who after 20 years. We do know that there is some evidence or supportive evidence of motor vehicle crashes, low birth weight, chronic bronchitis, which is not surprising, most worrisome are mental health aspects, schizophrenia, that may be associated with use in youth and associated with high THC. These are things that are not entirely understood, but I think things that we need to take into consideration as we look at a medical program going into the future. We do also know that marijuana use is associated with other abuse issues. Now, this is association, not causation. So I'm not saying, and I'm not selling the gateway theory, but there is probably little hope to think that marijuana is going to get us out of the opioid crisis, right? I think it's a separate conversation, but we do know that a lot of people who do use cannabis also use other drugs of abuse. We know that this is Mississippi data, and these are hospitalizations associated with substance abuse. You can see the leader on here by far is alcohol, and I don't think we're surprised by that, but we have not made alcohol illegal, but we understand the dangers and the limitations. But we do have a lot of hospitalizations associated with opioids, but also cannabis, cocaine, and stimulants, which would include crystal meth. If we consider neonatal hospitalization, so for newborns, we know that marijuana is going to be the highest associated drug for newborns. So baby, and this is something we're going to analyze more closely in Mississippi to see what are those adverse events. But there are kids, there are babies who are admitted to the hospital in Mississippi because their mothers were using marijuana at a level that was adverse to their health. Again, we got to make sure that we understand the potential health issues and protect vulnerable folks. And you can see this is the breakdown of the demographics for people admitted, babies admitted for neonatal hospitalizations. You can see it was predominantly Caucasian with significant minority of African Americans. The vast majority are Medicaid followed by self-pay. So, and I'll go ahead and just run through all this real quickly so that y'all can ask me whatever questions you want to. So the other part that Senator asked me to talk about is kind of what we learned along the way. And I've broken it down by the program objectives that the State Board of Health put forward for I-65. And I'm going to talk about it in the context of what it would mean in the concept of maybe a statutory program. What we learned along the way, one of our objectives was to make sure we had an effective program. You know, and y'all have this stuff. I'm not going to go into in too much detail. Heavy involvement with the physician and licensing community was going to be very important. Protecting vulnerable populations. And I think this is something to spend a little bit of time on. THC limits, I think, are a very important consideration. That's where a lot of the toxicity is. And if you look at what the upper limits of use for FDA-approved THC, we're talking about 20 milligrams a day. Under certain interpretations of the 65, and we were working through that, people could be consuming up to 1,000, 2,000 milligrams of THC a day. So I think it's important to consider that there are potential toxicities, and we need to keep that in mind as far as potential harms. We certainly would be more supportive of non-smoking formats, right? Because we're the health department, we don't want people getting lung cancer or asthma. Make no mistake, just because we haven't seen a bunch of lung cancer from it is because we haven't been doing it long enough. There's nothing special about marijuana that's going to make people protected as compared to nicotine and tobacco. It's a consideration I think we need to take into account. Certainly, we need to ensure parental approval and safety for children with extra sort of safeguards, and then also have special analysis of advertising and packaging to make sure that it's not stuff that's like, you know, appealing to kids. If you go, I'm sure y'all have been through Colorado and seen all the signs and everything, and other places where it's, you know, it seems like it's very playful, and what it probably is because it's a recreational program. For community impact mitigation, certainly looking at advertising, zoning, and then also support for other agencies that wasn't really included in 65, but for mental health services, because there will be increased mental health issues. Law enforcement is certainly going to be an issue that needs to be considered, making sure that we have support for the increased expenditures we're going to see. Compliance is key, making sure that we don't have fraud or unintended consequences. A really robust seed to sale tracking so that we have 100% validation of all product that moves through the stream to prevent diversion and understand where the product is, and also for tax purposes. The other thing is, and I know this is going to be a big conversation, and I'm so glad it's y'all's decision to make now, is indoor versus outdoor. And this is something that we talked about a lot. And I'll just tell you from our conversations with other states who've been through this, it was recommended to us that if we're going to have a program, we begin only with indoor and greenhouse. And why was this recommended to us? What they said to us is outdoor growing is near about impossible to have that sort of accountability. It's a very easy way for there to be diversion. And it is the part of the program that invites out-of-state criminal elements and cartels into your state. They've had a lot of law enforcement problems. So I think if you guys are going to consider this as part of a program, I think that's a question you need to ask very seriously and look at what potential remedies might be if you're going to be looking at outdoor. Certainly, we wanted to communicate clearly with the public, preventing diversion. It's a lot of the same stuff we talked about before, and criminal involvement, the same sort of things. We did restrict certain felonies from participating in the program. Equity issues. That was a really tricky one. We spent a lot of time on this, but I will say I don't think any state has gotten this correct. It's not an easy thing to do, and for several reasons. Getting into the business has very high barriers of entry. What we discovered, especially from the growing perspective, is you need to have about $1 million to $1.5 million just to get out the door, right? And so what has happened in Oklahoma and other states we've talked to is people mortgage their house, right? They borrowed from their family, and they didn't have the capital or the experience to ride it out or to compete with people who had the sort of economies of scale, and they ended up going bankrupt and losing their house, right? So I think there are considerations to be made as y'all discuss this about what are the proper barriers to entry. And there were risks of low license fees, so people could get into the business and borrow a bunch of money and buy a bunch of stuff, but never really get product off the ground. Other thing is, I think, is looking at making sure that people who have, like we talked about before, is if you have somebody who has a nonviolent drug offense for possession, that should not be a barrier, because there are clear health equity issues baked into the war on drugs, especially as it relates to marijuana. And then understand that there will be other business. What we're told is there's a lot of ancillary business opportunities for for people who are like transporters or have other opportunities to have small businesses that are not quite as resource intensive. So making sure people are aware of those. And I think almost having like a business incubator for health equity purposes, so people can understand how to get into the business makes sense, understanding what the real risks are and the benefits. Certainly we want to prevent substance abuse. And those are some of the same sort of things. Supporting mental health services is critical. Having a medical format is really important, and THC that are at therapeutic doses. Also, obviously, fiscal sustainability is important, and product safety is key. A robust lab program can do a lot for you, and we had made a lot of progress in looking at what those elements would be as far as having those sort of components, and we felt we had a pretty good, strong plan for product safety. And that's all the information I have. I know you have some handouts there that kind of go over some information as well, some references. So Senator, I'll be happy to answer any questions.
During your remarks, I think I heard you to say, I know that you have driven through Colorado and seen the billboards. I'm not sure we've all driven through Colorado here lately.
In Oregon, so if we don't want to have our kids developing a marijuana habit, right, while their brains are developing, for sure. And if y'all have been through Colorado or Oregon or other places, a lot of times you'll see big signs of marijuana
I've just been hanging around here. Somebody told me there was a pandemic and I should stay close to home.
Well, this was before and after, right? So recent travel. But yes, sir. I mean, there are advertising out there that has sufficient whimsy to attract vulnerable populations.
When I was in law school in the mid 1970s, there was a professor who I knew of. I didn't know him very well, very dignified person who had cancer and was taking chemotherapy. And his doctor at the University of Virginia Medical School told him if he could get some marijuana, that it would ease the side effects, particular nausea associated with the chemotherapy. And this was a doctor in the mid 70s. And so I hear a lot of discussion from the medical community and the research community saying that there are limited uses for medical marijuana. And yet there's this public perception that it's like Hadacol. It's just good for everything. And there are obviously a lot of people who feel like they're getting good results from using marijuana. Maybe it's a placebo effect. Maybe it's just the effect of being high. But how do you reconcile the studies which show some but limited benefits from THC and marijuana compared to the overwhelming anecdotal stories that we hear?
This is not unique in our history. Back in the 1900s, you could get heroin over the counter and you would leave it on your table for your kids to drink if they felt bad. So that things make you feel good is not debatable, but whether or not they have a clinical impact, kind of like with the opioids, right? I think we fell into the same sort of trap with the opioid pandemic. I don't advocate for making opioids illegal. They have a very important use, but they need to be approached cautiously and appropriately. I will say, I'll just say from my clinical experience, I have dealt a lot with people who have different substance abuse disorders. And opioids, crystal meth, crack cocaine are very difficult to work through. And I certainly wouldn't put marijuana abuse on the same sort of level of that. But we have to have proof that it works. And there are some things that shows that it's not really effective for. So we have to let the science lead us, and we don't have as much science as we'd like. But we can use what we have. And for chemotherapy and for weight loss and for neuropathic pain and spasticity, those do seem to be things that it may be useful for.
Thank you. Senator Blackwell.
Thank you, Mr. Chairman. Dr. Dobbs, on your third slide that you had talked about known potential harms of cannabis.
Yes, sir.
We're not talking about the initiative process right now, but I think this is a perfect example why we don't need products or an industry in the Constitution. Because had this 65 not been struck down and there were health concerns, we'd have to have another referendum to withdraw that, which would be a lengthy process and probably put a number of folks at risk. Wouldn't you agree?
Yes, sir. And everything is evolving so quickly right now. It requires something that you can have some flexibility and some, assessment. So I do think having statutory capacity to change things and regulatory in some lanes makes sense.
Right. And now your second bullet point there is interesting. So had I smoked marijuana back in the day, I have the potential being an attorney today. I may have to say it again. They didn't get that.
Yeah,
you don't have to answer. You don't have to.
I've been much impressed by your clinical or your mental acumen.
You and your staff developed 10 subparts, rules and regulations. Is that correct?
Yes, sir.
And what was your source of that information as you went through and put that together?
We tried to assemble best practice from as many states as we could. We did have a consultant who was a national expert who previously had worked at CDC to understand policy implications and then fit within the context of I-65. So it wasn't a singular thing. We borrowed and used our input also from our friends at UMC. I mean, at Ole Miss, at the research center. So it was just a collaborative effort from multiple perspectives.
I thought you did a good job of it. Had it gone through the public comment period yet?
One of them did, or I guess the laboratory regulations hadn't gone through, but we hadn't had a chance to meet with the board yet.
All right. And did the legislature impose any requirements on your department to include any rules or regulations?
They did not, but I will say the legislature did help with a couple of impediments because the way that 65 was structured, it would have been very difficult. We couldn't procure IT equipment. We couldn't hire pins, and we also couldn't share money with state agencies. So thinking forward, if this is going to be a cross-agency collaborative event, we'll need to be thinking about those same sort of things that would keep us from meeting any significant timelines.
All right. Then, so you talked. On daily dosages, the 65 had language in there about 2.5 ounces of marijuana every 14 days, 5 ounces for the month. But nothing in regards to THC level for edibles or topicals and things of that nature. Should there be monthly limits or certain limits on how much a patient should possess at one time?
Yes, sir. I mean, from medical therapeutic principles, I do think that there should be an upper daily limit because there's a therapeutic index and, toxicity. I do think so. And we had thought about some of those limits and, we can talk about them a little bit. And there may even need to be for people who are like terminal or something like that, kind of like we have special dispensation for pain medicine specialists to go above the 50 morphine mill equivalents for opioids. There probably could be some discussion about that also.
I think, did you take a look at the Alabama bill?
Yes, sir.
In their bill, they had a limitation, a daily limitation on milligrammage, which I didn't particularly care for because I think that really should be up to the practitioner and between the practitioner and the patient to decide that. Would you agree with that?
Under some guidance, we're in kind of new territory, and physicians are not really very savvy with what those upper limits mean. I do think having some guideposts are helpful, and maybe having some options for people who are maybe at sort of advanced terminal stages can make some sense. I think the opioid stuff is a good analogy because right now physicians cannot write over 50 milligrams a day unless they have pain medicine credentials.
But the patient could possess more than 50 milligrams of tablets.
Oh, yes,
Yeah,
sir.
right.
Yes, sir. Consistent with that daily upper limit. Yes, sir.
Right. All right. Thank you, Dr. Dobbs.
Thanks, sir.
Senator Harkins.
Thank you. I had a colleague or two text me and ask me to ask a question. I guess they can't participate via Zoom, but hypothetically, if the Supreme Court hadn't ruled the way they did, when was the program set to go into practice?
We were going to have the regs pretty much all reviewed and voted on by July 1st. At least that was in our schedule. And then August 15th was the date that we were going to start issuing licenses.
Okay. And I know it's hard to answer a hypothetical question, but if we came back in a special session, how long do you think it would theoretically take you to get the wheels in motion to adopt? I mean, I don't see anything being majorly structurally different than what you've already, I think you've kind of addressed a lot of the issues, so it's not something that would take y'all a long time to change the regs or the base that you currently have. But do you think it would be something that you would, Department of Health would be able to quickly get into practice, or is this something that you think would take a while?
I think it would take a while for two reasons. The same that we knew coming into it. I think the regulations we could, whatever piece of regs we had, we could get through pretty efficiently. But it's going to take probably 6 months to get IT systems in place that have your compliance controls in it, even if you could bypass the procurement law. So I think that's very important. And then the other thing that's going to slow you down naturally is setting up the product safety labs. And that's not really going to be a thing that's going to be a regulatory requirement, but it's going to take a long time for them to get operational, and nobody can sell product until you have safe product tested. And so the quickest that I think that could happen from the free market perspective, and other people may disagree, but starting over, and I think people have sort of kind of pulled back, would be 6 to 9 months.
Okay. I think I've seen some areas that you draw some concerns, or you say things that we need to think about. Is there anything that stands out, or is the most important part of this that you would substantially change, or you would want to do in a different way? What is there one or two things that stand out most to you that are probably the most important to consider, or what would you change in this process or with this law that would make it better?
Probably the harms that people get are from chronic long-term use of high THC, especially in youth. So making sure we had stuff in place that would limit daily THC consumption. A lot of folks who are going to use medical marijuana are going to use it episodically, right? They're not going to use it all the time. And so, for someone using modest doses of cannabis on the weekend or 3 days a week, whatever, I think the harms are pretty modest. What would worry me though is teenagers who are taking 100 milligrams of THC 3 times a day would be very bad for them. So I think making sure that we protect the vulnerable folks is important. The other thing is, I mean, we're not going to be supportive of smoking, but I think a lot of people, I think that's what people want. People want to smoke marijuana. They don't want to take it in a liquid under their tongue. But we're against those harms, right? The other piece is, I do think there needs to be consideration of people who are in jail for things that would sort of be legal now. And then as operationally, I think it would be good to have people doing things that are within their wheelhouse. I mean, we can do the regulations and the dispensaries and the labs and that sort of thing, but we're not very good tax collectors. There's a whole system for that. So having the partnership of revenue and ag would be fantastic.
Okay, thank you.
Senator Wiggins.
Thank you, Mr. Chairman. And my question kind of goes along the line of what Chairman Bryan asked, which I thought was very, gets at the heart of the matter on this, which is the dichotomy between the what the people want and what the evidence or science says. And so if we're doing a medical program, and which presumably will go through doctors to prescribe, my understanding of how that tends to work is doctors research the material, research studies, the scientific method, it's developed. And so then they're going to be prescribing something that by your own admission says has been understudied. So are we putting doctors in a position to do something that they don't have the data and the information to fairly and accurately, but fairly care for their patients? Do you understand my question and where I'm going with that? Because I think it goes back to the lack of the scientific method and how that gets developed and what informs doctors in caring for their patients versus prescribing it what they have. Can you answer that?
Yes, sir. And I think a lot of physicians feel that way. And most docs who I talk to say that they will not prescribe medical marijuana for that same reason.
Okay. That was going to be my question. Why is that?
Because that they don't feel comfortable that there is evidence base for what they're doing. The way that it was in 65 is you get a certification. It's not a prescription, right? So I'm not going to prescribe 10 milligrams of tincture or nasal spray 3 times a day. It's going to be it's a permission slip to go buy marijuana up to, 2.5 ounces every 2 weeks. There would probably be some advocate physicians, and there's some out there who probably would be high producers. They'd probably use a lot of it. So, and the other thing is doctors try to do what their patients want for them to do. That's why there's so much direct to consumer advertising from the pharmaceutical industry. So and especially if someone's already using marijuana, I think what you would see is people who are using it already. And they say, "Hey doc, I'm using this already. I'm doing well. This is my thing. Can you cover my back on this?" And I think you'd see a lot of that.
So then with the certification, this isn't really a medical program. It's a certification program.
That's the way it was designed. It was a doctor would certify you to buy whatever form of marijuana you like.
Are doctors is that why they went to medical school? Is that what they're there for, to certify things or to treat patients?
Most physicians are uncomfortable with that role versus, given a prescribed medication versus I don't give someone a prescription of Lasix and just say, just take it as you think is right.
Okay. So then on that question, I mean, clearly there's 30 plus other states that have done this, and clearly there's doctors in those states.
Mm-hmm.
So how's that been handled or rectified in general?
I do think that, a lot of other states are more restrictive on the medical side. So most medical states were not going to be as permissive as this program.
Initiative 65.
Yes, sir. Yes, sir. So a lot of them, like if you look at Alabama or Louisiana or Arkansas, Wisconsin, Ohio, you can see that they're a lot more constrained in what's permitted. And so for those states, I don't think it's been such a challenge for the docs. And the other states,
Oh, I'm sorry to interrupt, but that's because it's more of a medical program that fits under the medical doctrines that physicians and medical practitioners operate.
yes, sir. Yes, sir.
Okay. And then you were going to say the other states?
I'm not quite sure. I mean, I know there have been some issues with, docs who get kind of carried away. Same thing with opioids and everything. But, there'll be advocate physicians who think it works for everything and they'll prescribe.
If you want to answer this, so I go back to my original question, in understanding what you said about protecting minors, why not legalize it recreational and not do the medical side of this and maybe like alcohol or something? Then the doctors aren't in that position.
I think that is a legitimate conversation that needs to happen. I do think that if you look at Oklahoma, I think most of the users there are not strictly medical users under our definition. I do think that a lot of the demand for this from the most vocal advocates has been from a recreational perspective. In a way, I think that a well-managed recreational program would be less dangerous than a medical program where people think they should be taking doses all day long on high THC. I think it's dangerous versus someone who might use it recreationally from time to time. I think that's a legitimate debate.
So there's some actually public health benefits to legalizing but regulating like that.
I think that there are downsides from the medical program that could be avoided by recognizing that it's really a recreational and then approaching it if that were a way that y'all thought we should go.
And last question. So it's my understanding that the Initiative 65 was based on the Oklahoma model. Do you know if that's the case?
Functionally, that was the state that seemed most similar because there were, no restrictions on the number of dispensaries and, card holders and, that sort of thing. So it seemed very analogous. Yes, sir.
And the playbook that was used in Mississippi was used in Oklahoma first.
I'm not sure where, I just know that the outcomes were the same. The language was different, but
yeah, there's a
outcomes.
Politico article that made the connection.
I see. Yes, sir. I'll read it.
Yes.
Senator McMahon.
Mr. Chairman, thank you. Dr. Dobbs, thank you for taking time to be here today.
Yes, sir.
I don't use illegal drugs and I don't encourage anyone else to use illegal drugs. So I'm going to ask a couple of questions. I'm just unaware. But in Initiative 65, the initiative allowed for a person to have 2.5 ounces on their persons every 14 days. That's Section 8, Paragraph 1. What's the dosage in 2.5 ounces, or how many marijuana cigarettes, if in a normal size cigarette, would that give someone access to a day?
10.
So 10 a day.
10 a day. Yes, sir.
And what would be that dosage?
Well, it depends on the percent THC within the plant. And that's the real challenge. And if we calculated it, it could be anywhere from a few hundred to 500 milligrams a day if it were sort of high potency. So that's the real kicker, is the percent THC.
So it could vary per plant or per crop.
Yes, sir. Yes, sir.
Okay. And what's the dosage that you recommend today? You say 20 milligrams?
Well, that's what's currently recommended for the Marinol, and also for the Salvatex is about 48 milligrams, which is a little bit higher than the other one. So that's about 50 milligrams a day. I guess 50 milligrams a day is at the upper limit of what's used elsewhere for approved, sort of FDA type purposes.
So if I was to ingest or inhale 20 milligrams of THC into my body, what would be the effect of that? I would be high, but for how long would you say, an average 180-pound person?
Boy, I don't know, but I will say that with the edibles, a lot of states have adopted a 10 milligram per edible dose to prevent sort of overdosing. And so a 10 milligram pedophile or whatever is kind of like the amount that a lot of places have adopted.
Well, the point I'm driving to is in support of what you've said. So if someone could have 10 cigarettes a day, and let's say that effect was to last for an hour a day, hour and a half a day, you're only awake 16 hours a day, you sleep 8 hours a day. Basically, you would be intoxicated the entire day if you were consuming 10 cigarettes a day. Would you agree with that assessment?
Yes, sir.
So you would pretty much be in a position where you may not be able, you would be impaired to operate a vehicle or machinery or participate in some type of work program or a job. Would you agree with that?
Yes, sir. I think it would be unsafe for people to operate machinery and drive under influence.
I wanted to get that stated for the record. The other thing, I'm sorry, one of the other things, two other issues, just quickly on the free market principles, where you said, that there was capital, people would borrow money, that you would not encourage Mississippians, it might be an economic disadvantage. You wouldn't encourage them to borrow money against their home, is the example you gave, to go into this business. Is that an accurate statement?
I think there are dangers for people, and certainly free market principles are what they are, and people can take the risks they want to take. But I do think that it's important for us to acknowledge that there are significant financial risks. It's not going to be, during the gold rush of California, who made the money? It's the people who sold the shovels. It wasn't the people out there looking for gold.
I think we have to be careful I think we have to be careful in laying out rules and regulations for something like that, because would you tell a poor family in this state not to take a mortgage out on their home to send a child to college because they may or may not complete college? Would you tell a poor family not to take out a mortgage or borrow money to start a business where they may or may be unsuccessful? And I think we have to be careful not to apply those financial prejudices in law to keep average Mississippians from the opportunity for economic mobility. And I would just, for the record, I wanted to state that and ask you to please consider that as you move forward with these rules and regulations. The last thing I wanted to share, you were talking about the labs, and I think you and your team have done a good job establishing rules and regulations. But you said that it would take a lab 6 to 9 months to be operational for testing. And I disagree with that assessment based on conversations that I've had with some labs. They're telling me that they could start and have labs up within 45 days. And some labs that already exist could be converted and have results in 10 days. Would you disagree with that?
I do think it's going to take longer than that, because once we pass the regulations and get everything set up, it'll take, a 45-day turnaround period seems pretty reasonable. But if you consider the rulemaking process, the law, and then that, we're still looking at about 6 months. And then the investment piece, because we know people are sitting around. So I do think that some labs that are pre-positioned could probably be operational within a couple of month timeframe.
Okay, thank you. I appreciate you answering my questions. Thank you, Mr. Chairman.
Yes, sir.
Senator Blackman.
Thank you, Mr. Chairman. Dr. Dobbs, you were mentioning Colorado and Colorado's medical marijuana program. I believe theirs has been in existence for about 21 years.
Yes, ma'am.
Have they produced any studies related to their program?
Yes, ma'am. They have studied it pretty extensively.
And in their studies, do they show what the medical marijuana, what benefits it has provided to its citizens, or harm?
There's surprisingly little data from Colorado on clinical benefits. But keep in mind, that's not a good way to get, you have to have clinical trials, and they haven't really done clinical trials. What they have done is they have a report on the potential dangers of high dose THC. That's something that they've looked at, and certainly some of the motor vehicle stuff and the machinery things. They have transitioned over to a recreational program as well, and it seems that most folks have transitioned. But I did go over to Oregon for a different process, and I visited a dispensary there. And the thing that they did with the medical, though, is I asked, why do y'all even have medical? If you're there for recreational, you can get about the same amount of marijuana that you could get through 65. But if you were medical, you could get up to like a half a pound of marijuana a month, something insane. And I can't imagine that that's not only for diversion. I can't imagine anybody smoking that much.
Have they done any studies to show what effects that half a pound a month has on?
I haven't seen that, ma'am.
And my last question, if our physicians were to begin to prescribe medical marijuana, Do you all have like continuing medical units, medical education in this area?
We do have some that we could do already, and we certainly have expertise at the, with Dr. Henderson and some other folks, but we could build it out. That would not be an impediment. We could build out the CME piece.
Thank you.
Yes, ma'am. Thank you.
Senator Felon, and after Senator Felon, Senator Blackwell, and then after him, we'll move on to the next speaker, Senator Felon.
Thank you, Mr. Chairman, and thank you, Dr. Dobbs. Let it be said, I think you've done a fantastic job in your entire role at the Department of Health through the pandemic and helping us navigate our way through that. It's been crazy. I don't envy your position at all, but thank you.
Thanks, sir.
You can make a lot more money doing other stuff, and we appreciate your service. Let me ask you a couple of questions on this, if you don't mind. So do you recommend an actual prescription should this program be enacted into law versus just a certificate or permission slip, as I think you called it?
I do think if we were going to look at a medical program, a prescription consistent with the normal lanes of progress of process makes sense. Yes, sir.
And would that be easier on your department to actually regulate, or for the medical board to regulate, if physicians were abiding by the rules versus this whole permission slip where you can get approved to purchase the product and then you just purchase however much you really feel like you need?
I think there'd be a lot better awareness and a lot better ability to discern, people practicing within, regional guidelines and science. Yes, sir.
Have other states that you've studied their programs, have some of them use the prescription method versus the certificate method?
Some have more prescriptive type of processes, but I'm not as familiar with what those look like specifically, so I'd have to research that more.
Would it be your recommendation to the legislature to go more in the direction of an actual prescription method that tells you the amount and the prescribed doses, how many times per day or per week or what have you?
Yes, sir. For medical purposes, I think that makes a lot of sense.
What would be the benefits of doing it that way versus this other way that the initiative proposes?
Well, it would, if it's in the physician context, it would help them make a decision based on the mode of delivery, right? Sometimes we give medication through inhalers or through pills or whatever, and also a frequency, and you could also help avoid unintended harms by having too much, right? So I do think there's been, and you can ramp it up slowly, right? You can start and say this dose is sufficient. And then if it doesn't work, then you can get back and you can, but also too, maybe it's not really working for you. You need to do some other treatment along with it, right? It's not just, if you have spasticity, you might need to use, muscle relaxers and other things too, in tandem.
And also, what about the review of that process? So if your health is obviously an evolving situation, if you're on other prescription drugs, how those drugs interact with the cannabis products. Is that a concern that you might have?
Absolutely. And that's have a comprehensive medical relationship to look at those interactions. Yes, sir.
Switching gears, if this program moves forward, have you looked into things like banking, for instance? I know you were thinking about setting up the regulations. I understand that there are some challenges for the banking world, given that this is still considered an illegal product and many banks choose not to accept deposits. How have you suggested or thought about navigating through those situations?
There would be, as looking at, there was limited impact that we could have from our regulations that would help banks, except for there were some things that would be very useful for them. What they really needed to know is who are bona fide businesses in good standing and having proper registry so that they could make sure that they're not, taking illegal money, right? So they would have to have, basically the verification system is the main thing that we could do, but certainly they have a lot of other challenges that they had to be worried about that are sort of outside our purview.
Exactly. And what about like workers' comp laws, things of that nature? If you're going to legalize a product that has heretofore been illegal in most circumstances, how does that interplay work with things like our criminal justice system, both the enforcement provisions, but also something as simple as being hurt on a job and whether the state workers' comp folks are going to authorize payment for an injury if there is THC in your system now that it's a legal product?
I can see that being a real challenge. It's not something that we had a lot of insight into, I'll be honest. Yes, sir.
Gotcha. Thank you very much. I appreciate your help.
Thanks,
Senator Blackwell.
Thank you, Mr. Chairman. Senator Felon, we took care of a couple of those provisions in the last bill that we passed, House Bill 119, the last Senate version, took care of the banking industry. And I believe we had some regulations in there also regarding workers' comp in protecting employers. Dr. Dobbs, I have I guess a statement from Dr. Sinclair. Are you familiar with him?
I'm not sure
He's
who he is.
at Mississippi Baptist Medical Center, neurophysiologist there.
Okay. Yes, sir.
Anyway, he asked, it should be enumerated that the Mississippi Board of Medical Licensure or other practitioner oversight board is allowed to discipline practitioners that inappropriately authorize cannabis. And his example is a dentist providing cannabis to a minor with epilepsy without conventional anti-epileptic drugs, or providing cannabis to patients with epilepsy where they are stable on treatment and have not had seizures in several years. A nurse practitioner placing a patient with glaucoma on cannabis instead of referring them to ophthalmology or an optometrist. Would that be a provision that we should take a look at as we move forward?
And I think giving the licensure boards directives and an authority to manage those things is going to be really good. I think, the question of, is it just physicians or is it nurse practitioners also? I think that's something that y'all need to look at very closely. I know those were different things. Regulating individual practices can be very difficult. A lot of the medical boards are basically, it's only when something goes wrong do they get in there. But building in some safeguards, I think, especially the parental consent piece, making sure that's really robust, and letting the licensure boards do their job, I think would be good. Yes, sir.
Okay.
Thank you, Mr. Chairman. Thank you, Dr. Dobbs. One of the questions that has not been asked, and with the passage of 65, you all had this thing foisted on you. You're unwilling to come to the party, but you were brought to the party. So going forward, is it your position that you've done all this work, and it sounds like great work? Are you interested in and willing to take on, if given a choice, the operation and maintenance of this program, or would you advocate, along with the help of revenue, ag, and commerce, are you willing to take on this responsibility, or would you recommend sending it to an independent board?
We are certainly willing to do the will of the legislature, and I think taking on the things that are within our wheelhouse, I think is certainly, it would be the Board of Health would have to give me that sort of directive as far as like what they think, but we would be prepared to do those things. I will say, if you do an independent commission, we have seen that in other states. Talking with my team, I think building a new agency de novo does have its own sort of challenges. As CPS, it was kind of a hard to kind of scale that up, was a challenge. So I think there'd be some natural strategic challenges doing that, but I think it would just take some in-depth conversation.
Thank you.
Thanks, sir.
Dr. Dobbs, we appreciate your coming and spending time with us, and we appreciate your availability to this committee and to the legislature over the past year or so when you've had a number of matters to deal with. So thank you again. We appreciate it. Our next speaker is Sherry Veazey, Executive Director of the Mississippi Municipal League. And I must at this point make everyone aware that it has dawned on me that we do not have a sergeant at arms right now. And I mentioned that because I had asked Ms. Veazey to try to refrain from making comments about a local option sales tax. And in that conversation, I had made reference to the sergeant at arms, and I felt this was my one method of defense, only to find we don't have a sergeant at arms. So I'm now completely at your mercy, Ms. Veazey.
Okay, well, I had some PowerPoint slides on local option, but I'll skip over those today. Thank you for having me here today, Mr. Chairman. And just so y'all know, I think most of you know the background of MML, but we are a private association. that represents 289 cities in the state, cities, towns, and villages. And as their official association, we spent a lot of time in training and education, research, technical support, and advocacy here in this building and in DC. Now that the Supreme Court has overturned Initiative 65, the MML membership wants to be at the table for these discussions. And I especially want to thank Chairman Bryan for having us here today, because that's an excellent start in our membership having a voice in this program. Last October, the MML Board of Directors, as some of you probably know, publicly passed a resolution to publicly oppose Initiative 65. But I want to make it very clear that our resolution stated that it was not an opposition to medical marijuana. It was an opposition to it being in the Constitution. We felt like that was not the appropriate process for establishing a medical marijuana program. The MML Board of Directors feels the most prudent way is to allow medical marijuana through a bill that's introduced in the legislature, fully vetted and studied, where people can attend hearings and committee meetings and lobby for rules and regulations that could establish a safe, effective medical marijuana program in state statute. As we've heard today, there are, I think, 38 states who have medical marijuana. And I think the value of having this done through the legislative process is that we can look at these other states. We can learn from perhaps maybe mistakes that they made on the front end or improvements that need to be made. And of course, this body in the legislature can make those changes along the way if they're needed. After 65 passed, between the time it passed and the Supreme Court decision, I had a lot of calls from municipal officials, and I think their number one concern was public safety and security. What kind of security would these facilities have? Retail dispensaries or treatment centers or testing centers? Would there be background checks for owners and employees? I think some of that's been talked about. We had mayors who were also concerned, or law enforcement that was concerned about how edibles or gummies would be prescribed in an effort to protect children from accidental use. But the reality of any medical marijuana program, whether it was Initiative 65 or whether it's one that the legislature passes, is that the burden of making sure the program is legally operated is going to fall on local law enforcement. And so we anticipate, whatever happens, that there will be additional training and education that local law enforcement will have to go through to make sure that they can properly enforce a medical marijuana law and protect citizens from unlawful use of marijuana. Another reason that the board opposed Initiative 65, which is something that's already been mentioned, was that there were no taxing provisions, and they felt like it should be taxed and the tax should go in the general fund, and that an 18.5% diversion should be sent back to the local level to help with things and perhaps offset additional public safety costs, depending on how many dispensaries would be located in a city. In the matter of zoning, and that's been mentioned too, that's a huge issue for municipalities. Many municipalities across the state have invested much time and funds and thought to developing a comprehensive plan of how the land use in their communities. That includes policy development, historic preservation programs, architectural designs, standards, code enforcement, and ultimately cities are trying to create a community that provides a greater quality of life for their citizens and protects property values. So the zoning issue was huge for our board when they looked at what the language in Initiative 65 said. We believe that any law that's passed by the legislature should include protections and zoning authority for all municipalities who are able to regulate not only where the dispensaries are located, but perhaps the number of dispensaries that are located in their city. We've heard today of the discussion of a possible opt-out provision in legislation. We didn't see any language like that in the previous bills that were introduced last year, but I feel very confident that our board would want to see that language. And when you talk about an opt-out provision, that goes to the very core of what we talk about a lot in this building, and that's local control and local authority. So I think our board, if they had an opportunity to review that language, would want to issue a support statement on that. And just finally, I would encourage you, we know 38 states have passed it, to look at any possible negative impacts that have been, happened for municipal governments, and to mitigate those with the proper regulation that addresses all the aspects so we can have a safe, beneficial medical marijuana program for all of those citizens who desire to have it.
Thank you. Ms. Veazey, are there questions? If not, I'll recognize Senator Blackwell, who has a question.
Thank you, Mr. Chairman. I just want to clarify, you do support or would support a referendum process to allow, like you said, local authority, let the people decide locally if they want to opt out of a medical marijuana program.
I would have to take it to our board of directors, and I think they would probably support it, but I can't say because I haven't seen the actual language. But I think from what I'm hearing, it would be something they would be very interested in. There would be some that would want to take advantage of that for sure. So that would be a policy statement that they would need to issue.
Thank you, Ms. Veazey. I appreciate your coming here today, and I would mention that one of the reasons, did you have it? One of the, Senator Blackman.
Thank you, Mr. Chairman. Ms. Veazey, you keep referring to your board. How many people are on your board?
About 100.
100. And how many members do you represent?
Well, individual members, it's hard to put a number on it, but we have 289 member cities. And our board is appointed, just so you'll know, from the 3 Supreme Court districts by that officer that's elected from that Supreme Court district. So we have a pretty good representation of small, medium, and larger cities on our board of directors.
And when you all take a position, do you survey your member cities, or is it just, it's the board?
The board, because the
Okay.
board is appointed by the officer that's elected by the entire membership.
Thank you.
Thank you. Again, Ms. Veazey, thank you for coming. And one of the reasons I think your testimony was helpful is that regardless of how we got here, we're in a situation where I think we're likely to have a bill that goes through the legislative process. You've mentioned a number of technical matters, in particular zoning. I'll say 2 things. I'll bet going through the process that almost a consensus could be reached among all the parties about some of the matters you raise, and the ones where there's not a consensus, you'd probably prevail on some and not on some. But I think this is an example of the benefits that we have now, however we got here, of dealing with a piece of legislation that can be amended as it goes through the process. So thank you again for your time, and thank you for your self-restraint. I always appreciate self-restraint. Not
Thank
that
you,
I
Mr.
exercise it, but I appreciate it in others. We now have Dr. Larry Walker, who's the Director Emeritus of the National Center for National Products Research at the University of Mississippi. It's interesting that we have had for decades a research operation about marijuana at the University of Mississippi. So we have particular expertise right convenient to us. Thank you for coming, Dr. Walker.
Thank you so much. I'm not sure how that mic's going to work. If y'all aren't hearing me, please raise your hand. So thank you for the chance to speak with you. I'm preface this by saying that my background is as a pharmacist and a pharmacologist, a drug researcher. I don't know a lot about some of the other issues that y'all have to deal with in terms of putting together a program like this or considering, but I would like to talk to you a little bit about this from the standpoint of, as we speak of a medical marijuana program, what does it really mean to us? And many of you have touched on ideas about this already. I still work at Ole Miss, but for about 20 years, I was involved administratively in the program for growing marijuana for the federal government for research. And you may have heard lots about that. Some of it probably not true, but I'd just like to let you know, I'm coming at this from a standpoint of a program where they've learned a lot about how to grow, how to control quality, how to understand the chemistry. And I'm going to touch on a few of those things, but not great detail. Mainly, I want to talk about how we deliver THC medically. How do we medically create a program that's medically sound? Let me see if I can get this to work. So I've just got 5 points. 4 of them are really short, and I'll try to minimize your time. First of all, when we talk about medical marijuana, I think it's just important to understand that there are more than 120 cannabinoids. You've heard of THC, you've heard of CBD. There are more than 120 that have been described in marijuana, and some of them are probably not important, but it's really important that we understand that growers are increasingly able to manipulate the concentrations of these different cannabinoids. You've heard of high CBD cannabis. It's available everywhere now, but there are growers who are growing high CBG cannabis, and we won't get into all that. I'm just wanting us to bear in mind that these products are very complex, and they can change over time. We know a little bit about THC and CBD medically. As Dr. Dobbs mentioned, there's a lot more research that needs to be done, but we do know that there are medical benefits. There's no doubt about it that for certain indications at certain doses, there are medical benefits. THC is known to be psychoactive. It's very potently psychoactive. Delta-8 THC is also psychoactive. You hear a lot of buzz nowadays about Delta-8 as if it's safe. No, it acts like Delta-9 THC. And so these things are being kind of used in a quasi-medical sense to create products that create a market, I should say, for products that might be sold in that way. Potential benefits, a few of them are on this slide. For several of these, studies have been done that have shown medical benefits. The Marinol that Dr. Dobbs showed on the slide has been approved for these first 2 indications here. Others are probably coming down the line, other indications. And so there's no doubt in my mind as a pharmacist, as a pharmacologist, that there are potential medical benefits in the cannabis plant. But that also implies with any medical treatment, dose matters, delivery matters, product quality matters, monitoring of the benefit, monitoring of the risk. All those things matter if you're really talking about a medical program. And so these are things I think that need to be carefully considered as we put something together for Mississippi in the future. What is it? 2.5 ounces of what? I have a prop, and this is not marijuana, okay? So don't anybody think that I'm bringing marijuana in here. I have a prop. I want to show you. This is 1 ounce. This is 1 ounce of dried plant material. It's parsley, okay? So, but this is 1 ounce. The program allows 2.5 ounces every 2 weeks. The language needs to be clear what we're talking about. If you're going to write something into a bill, 2.5 ounces, it needs to be clear what it is. I'll get back to that in just a minute. But from some of the language that's been floated, it's 2.5 ounces presumably of plant material, of marijuana plant material. But then there are all these other things that might be included too: extracts, gels, gummies, oils, whatever, with no real relation or real bearing to that 2.5 ounces. What does that mean? How do you compare them? How much of an extract is equivalent to 2.5 ounces of plant material? Those questions are wide open, and they really need to be addressed in a program. I'm not going to go through all these, but you can see these are all things that are really important to understand about products you might be using in a medical program. 2.5 ounces of, let's say, Dr. Dobbs was talking about 10% THC marijuana, which is maybe I would say probably a minimum street value today, minimum street concentration that people would like to buy. If you extracted that, you get something that looks like this of pure THC. If you clean that up, that's equivalent to 700 high-dose Marinol capsules. 700 high-dose Marinol capsules. It's a lot of THC. It's a lot of a potent drug. 10 joints a day, you wouldn't be walking around if you finish 10 joints a day of 10% THC. I'm not saying it's going to kill you. I'm just saying it impairs you. It impairs you tremendously. You could take that amount, get your whole family high once a day, every day for 2 weeks, and still sell 50 or 60 joints on the market. Okay. So it's just really important. Why is something like that in a constitutional amendment? Why is something like that even in a legislative bill? Those are things that medical professionals need to sort out. And so bottom line for this program, or for my comments about this, we need to be able to make it medical. If it's going to be medical, make it medical. Let medical professionals design it and run it. Dr. Dobbs and them have done a great, unbelievable amount of work in the last few months. Chris and all the staff, really, I couldn't believe it when I saw what they had done. They know a lot about it now. But they're constrained by what what's going to be legal. Well, how do you create a framework like that? So this is, I said this already, this is Marinol, high strength, 700 capsules equivalent for 2 weeks. Now, the people who would challenge about this would say, well, you don't get all that when you smoke the material. And that's true. You won't get all that 700 milligrams. But what you do get, it goes straight to the brain. When you smoke marijuana, what little you do get, you get this rapid penetration to the brain. And that's what gives you the high. And that's what users who want to be able to use marijuana for the psychoactive effects, that's what they want. And so it's just important to bear these quantitative aspects in mind. Evolution of state medical marijuana programs. Senator here touched on this. They've all, just about all have gone recreational. All the early ones, especially the ballot initiative ones, they went eventually recreational. I'm not saying that's good or bad. I'm just saying that's what we're dealing with. And probably you can't, we have a trend going in this country and we have to deal with it. Okay. But again, if it's going to be medical, make it medical. Sound medical approach. This is not exhaustive. I'm just trying to think out loud with y'all. Designed and run by the Department of Health, or maybe other agencies would need to be involved in this. Roles for physicians, pharmacists, health professionals that help in the design of it and ensure that you get medical benefit and you minimize risk at the same time. Quality products. Do we just allow anything and everything that might, someone might come up with? What about well-defined products that deliver a certain amount of THC by inhalation, by oral, by whatever, that that a physician can prescribe. By the way, the question about prescriptions, I understand it. The way the program envisioned so far would be you would have a card, and then you go to a dispensary and you basically pick what you want from the dispensary. This is the way many of these programs work in other states. You have a card, you go to the dispensary, you buy skunk berry, you buy purple haze, you buy whatever looks attractive to you, and they call that medical. It's really against sound medical practice. A patient registry, documenting what's going on, follow the patient, see if it helped. You know, it would be a great contribution to public health and to science if we had experience with 400 patients in Parkinson's disease, and we said, you know, if they take this dose, 75% of them will be helped, you know, be helped in their symptom control, something like that. If we were able to do that, it wouldn't be just an add-on, here's another medical program. It would be something where we could really track what's going on and say something about the outcome of it and help patients in the process. I think we need to help patients. We need to make something available for those where they have a legitimate medical need. But I'm not sure we'll even know if we helped them, if we approach it in a way that doesn't have good medical design, medical oversight. Legislative issues, y'all, you know your business, but my suggestion would be create a framework. There are legal things that need to be taken care of. Create a framework, but let health professionals design and operate the program within the constraints that they know will be good for patients and good for the healthcare community as well. That's all I have. Thank you.
Questions? Senator Wiggins?
Thank you, Doctor. I just want to, I guess, highlight what you said, which was if it's going to be medical, make it medical. That's what you said, right?
Yes.
And you're familiar with Initiative 65. And it seems to me from the testimony that I've heard here today, there's this friction between what is medical and what's really what people just want to use as recreational. And it seems to me that Initiative 65, as got put before the people, was not medical. I mean, is that an accurate statement?
I think there were a lot of provisions in I-65 that made it really hard for it to be a true medical program.
I mean, that's what I'm hearing here today is all our medical professionals who are charged by their ethical, and you're a doctor, but I know you're by their ethical positions are having a real issue because of the things that they have to abide by. And it was being told to the public and put in our Constitution as medical when it appears that it's not really medical, at least not purely medical. And what you're saying is that if we, the legislature, to go down this road and it's to be a medical program, then we need to focus on that. But I think, and correct me if I'm wrong, that if we do that, there's going to be a lot of people in Mississippi who want it to be recreational, who aren't going to be happy with a strictly medical program. Am I right in saying that?
I think that's absolutely right. Yes.
And the reason, I'm guessing the reason why all the ballot initiatives in other states have now gone recreational is because you can't sustain a purely medical program based on the science, and people just simply want it to be recreational.
Well,
is that
in many, I won't say all, but in many of the early ballot initiative states, it was just a stepping stone to recreational.
Right. It was sold so that they could politically get it passed, with the ultimate goal being recreational, which goes to the point I made earlier. Like, this is for us to decide, let's take out the middle step and let's just consider going to this, because that's where the states are saying it's going. So I'm with you about if it's going to be medical, it needs to be medical. But this selling to the people that it's medical when it's really not, I think is what got a lot of situations or people upset. And there were people who sold it as medical when it wasn't medical.
Yeah.
And I appreciate your testimony, and I appreciate everybody here, and I appreciate the chairman for bringing this up.
Yeah.
So thank you.
I
And
would-
yeah, if you have
I-
anything else to
I would
say.
just emphasize that I do believe there are legitimate medical needs, and I don't want to be taken as ignoring or minimizing those, but I think they could be met in a medical way. And
No, and I've talked to patient on the way up here. I talked to a very nice lady who wanted it for medical needs, and I believe there is that position, and we need to take care of that. But I think we also need to realize that if we do it purely medical based on the science, like I've heard here today, that there's going to be people out there who are going to be upset because that's not really what they wanted. They want recreation, which is totally fine. We just need to understand what we're trying to do. And I think that's what you're saying.
yes.
Okay.
And there's also, obviously, there's a lot of economic factors at stake here too, fiscal factors at stake here too.
Correct.
You made me think of one thing I wanted to mention though, because the conversation came up a little bit earlier about why aren't doctors, involved in the program and so forth. And I believe Dr. Dobbs mentioned that, or I'm sorry, maybe our first speaker mentioned that federal law, the current federal law really puts health professionals in a little bit of a quandary because they can't in many states, including here, they can't in their normal channels many of them directly get involved in the program. Let me just clarify that. For example, a pharmacist can't stock Schedule I drugs, and federally right now it's still Schedule I. So they couldn't, as a pharmacy, participate directly in that program. There would have to be some other framework in which they could participate, or some legal, some change at the national level, which may well be. But I wanted to emphasize our program at Ole Miss has been a federal program from the beginning, and everything we have done has been, overseen by the DEA, and we get a lot of complaints. Well, y'all restrict this and you restrict that. Well, we really contract with the federal government to do what they tell us to do. And that's all we can do federally that's all they let us do. So it's been a little bit of a problem for us too, to engage at the state level. How could we help somehow? How could we be involved? Because from a federal standpoint, we can't. And I think many clinics, hospitals that get federal funding, pharmacies, they're in the same situation. So that is a complexity that, has to be recognized and addressed somehow.
Thank you.
Senator Blackman.
Thank you, Mr. Chairman. Dr. Walker, the University of Mississippi's project is about, 50 years old?
Yes, 53 years, actually.
53 years old, and we supply the cannabis to all of the research around the country for federal.
We supply to the National Institute on Drug Abuse materials, plant material, purified cannabinoids, extracts. We supply it to them, and then they distribute it out to researchers who apply to them. We wind up distributing, but NIDA tells us what to do. In other words, it belongs to them and they tell us what to do.
Did we not also get a research contract?
We grow and produce all these cannabinoids and the plant material under a contract from the federal government.
Do we do research as well?
Yes, we do.
And how long have we been doing research?
Well, almost all the program. I mean, it's changed some over the years, but most of this is laboratory chemical research. How do you stimulate the plant material, the plants to grow, or how do you produce this cannabinoid or that? How do we get it out of there efficiently? How do we get THC out efficiently? It's been that kind of research.
And it's about 12 acres that we grow this marijuana,
No, we have,
cannabis or whatever it's called.
we have a plot that is 12 acre, a field that's 12 acres, a secure field. But we've never grown that much. I mean, typically NIDA will say grow an acre this year or grow 3 acres or whatever. Most years they say don't grow any. You know,
Okay.
I mean, they tell us what to do.
And with this acre or whatever they tell us to grow this particular year, is it grown in a greenhouse or is it grown outside?
So that 12 acres is outside. It's grown outside, one grow cycle a year in the years they ask us to grow. We have an indoor grow room, much smaller, that kind of supports maintenance and getting things ready. It's really important to understand that to control genetically what the material, you know, what you're producing, all of our plants are grown from cuttings from mother plants. So it's kind of genetically, vegetatively propagated cuttings, so they're genetically the same. So we'll create, let's say 5,000 little shoots indoors, and then we move them outdoors when it's time to do the growing season.
And do you have problems growing them outside with pesticides or with pests or anything of that nature?
Well, periodically there are problems that have to be dealt with when you grow anything outside, but we don't use any pesticides. We have a double secure fence with armed guards, so we don't have security issues. The limitation from my standpoint of growing outside is how do you secure it? And then growing outside, you get one growth a year in Mississippi, one growth cycle a year. Indoors, you can get 3 maybe. And so economically, it makes a lot more sense to grow indoors, but of course that involves some investment too.
Okay, thank you so much.
We have one more presenter, but before he comes forward, thank you, Dr. Walker. We really appreciate your coming to visit with us. The State Department of Health, Board of Health, has a marijuana subcommittee. And we have with us today the chairman of the marijuana subcommittee of the State Board of Health. And because of his position, he too has been spending a lot of time thinking about this. And so we have Mr. James Perry. And I've asked Mr. Perry to come and listen to the presentation and then give us his reaction based on his experience as a chairman.
Thanks, Senator Bryan. I'm reminded of something I think I heard some speaker of the House, or maybe it was the Lieutenant Governor, said at some point. He said, I think everything that needed to have been said has been said already. It's just not everybody's had a chance to say it. So I'm happy to contribute to that theory. Interestingly enough, the Board of Health was unanimously against Initiative 65 for a number of reasons. Not enough people in the state of Mississippi agreed with us on that position. So we after Election Day, we were tasked working with Dr. Dobbs and Chris and the people at the department staff to try to do our best to make the program workable and as medical as possible. And I think that listening to Senator Wiggins' and others' comments in the last little bit is really the place that we found ourselves in the last 6 months, where we were tasked with a medical marijuana program and getting it all set up. But we kept on getting this tension between the business interest and the medical interest. And I couldn't help but the people that were contacting me a whole lot, you know, good people that are trying to make a living and have no qualms with that whatsoever. They were interested, understandably so, much more in how much product do you sell. And that kept on being reminded, well, that's like an opioid manufacturer coming and say, how can you set up rules so that you can sell more opioids? Well, that was problematic for us as we were trying to craft what was supposed to be a medical program. And that tension of you got to have the business in the industry in order to set up the dispensaries and the growers and the processors and the testing labs. That's perfectly understandable. But there's parts of 65 that has been said many times that seem much more focused on the business than the medical. And the four that we kept on struggling with were the 2.5 ounces. And I spent a day with Dr. Walker and people at Ole Miss and learned a lot more about this in addition to all the education we got during the campaign. But it was the 2.5 ounces, the THC limit, the certificate versus the prescription, and then the delivery mechanism. Because on one of these poster boards up here, it references a code section as it exists on whatever the date is, July 1 of a certain year. And that lists all the delivery mechanisms by which you can get the marijuana, whether it's smoking, vaping, what have you. And as Dr. Dobbs said, that's just inherently not medical in certain situations. So that tension is really what we were struggling with. And to the extent you're interested, if you have narcolepsy and you can't sleep at night, you can watch some of our YouTube hearings of the board discussing this over the last number of months. We tried to address some of that medical of not wanting is only the product that needs to be given according to a doctor and with pain management specialists, hopefully. And we try to address some of that in the regulations, but just with the inherent nature of 65, that made that very difficult. We tried to do it with advertising. We tried to do it with labeling. We were going to address it with THC limits. We just didn't get to that point. But that same tension that I think y'all are about to be dealt with was what we did. I think the board would say we did not get to the point where the board actually approved the regs, and there was at least another module coming that didn't get put out. I think that except for those 4 categories, I think we were generally, you can kind of see from the discussion, I don't want to project how the vote would have gone. I think generally okay with most everything. There were a couple little things that we learned along the way that probably would have been tweaked. I think, for example, and I don't think Dr. Dobbs or Chris would object to me saying this, the testing lab regs said that it had to be a Mississippi lab. That seemed problematic upon further reflection because there's a lot of expertise out there in the country. And if there's one thing we wanted this to be absolutely perfect on was we wanted the labs to be able to tell us with absolute certainty what was in the product, how much THC it was, pesticides, et cetera. Well, I want the best person in the country, and I don't care if that person lives in Hawaii or Mississippi, doing that. So that's some of the process that we went through. But I think the feedback that the board would want to give to y'all now that I think it's appropriately shifting away from us to you, and that's one of the reasons why I was against 65 is that I was not elected to anything. Y'all confirmed me sitting in this room in a committee hearing, but
not only that, but the time to enter a motion to reconsider has long since passed.
Okay, I would like to actually maybe file that motion to reconsider in a couple of ways, but I think that as it shifts back to y'all, I think that my suggestion would be to try to, as much as possible, separate all the medical decisions from the legitimate business decisions. Because if you want to set up a medical program, go through the medical stuff, and then you set up the rules for the business separate. There's very legitimate discussions about taxation and zoning and permit fees and all that. But if it's medical, it should start with what the medical situation is. If it's not going to be medical and you want to make it recreational, that's go forth, have that debate, but separate the two. And it seemed to me that too much of it was coming back to the business rather than the medical.
Senator Blackwell.
Thank you, Mr. Chairman. I just want to try to clarify your position when you were talking about going out of state for testing or looking at other testing facilities. If I'm not mistaken, this has to be considered intrastate activity because it's illegal it would be illegal for someone to ship it to another state. Am I not correct
To,
on that?
to clarify what I was saying there, the first draft of the regs on the testing lab facilities required that every owner, agent, employee, I mean, everybody associated with it had to have a Mississippi driver's license. That's pretty specific. You know, so you're saying that everybody that might, for example, during COVID, you know, we were using lab during the height of COVID. It's not like COVID's over, but at the height of COVID, we were using labs in Mobile and Memphis for processing testing results. The idea that you would say that every single owner or agent or employee, even if it's somebody that may have a specific expertise whose driver's license happens to be in Nebraska, that seems like a pretty high standard. And I don't think that was a minor tweak we would have made in the regs.
But you're not implying that the facility, you're shipping to a facility.
I don't think you can. I think the facility has to be here, but just our draft of the regs said that anybody associated in any way, shape, or form with the company that owns it had to have a Mississippi driver's license. That was
So the regs were a little stiff.
a little stiff.
If we, you know, there's been discussion about between medical use and recreational use or adult use. If we, let's say we were to consider moving toward adult use, is that something the Department of Health would still play a role in terms of monitoring?
I mean, I think to echo what Dr. Dobbs said, that's not really our decision. I mean, we don't make the laws, and if y'all tell us to do something, or just it's the same theory. And look, I'm one of 11 board members at the moment, one of 10, I guess. But so I don't speak for the entire board when I say this, but I think we demonstrated after being against Initiative 65, the vote occurred and we tried to do our best to implement the law as it was presented. If y'all pass the law, we'll do our best to do whatever you do. Y'all were elected, we were not.
And I think you guys did an excellent job of taking what was in Initiative 65 and coming up with the rules and regulations that you did. Thank you for your responses.
Senator Blunt.
Thank you, Mr. Chairman. Thank you for coming, Mr. Perry. I'll just preface my remarks by saying I think those of us who are in these seats by virtue of the vote of the people should be cautious about saying the people didn't know what they were doing when they voted. I mean, that's how we all got here. So I think the people voted for medical marijuana, and we're now trying to figure out what to do. And part of that is the balancing act between what should be codified in statute and what should be left to an agency through its rulemaking authority, and that's what you've been doing. Can you identify, as you went through this process, working off what we thought was in the Constitution, can you identify things that you think we really need to look at putting in the statute, and things that we really need to not put in the statute and leave to the rulemaking authority of the board? And so as we begin to figure out what we should leave to the board and what we should codify, or is there anything there that you think we need to pay particular attention to?
Sure. And let me preface this by saying that at this point, since the board has not talked about this and has some sort of official position on some of this, is going to be my personal opinion as opposed to the board's opinion. We did have Dr. Dobbs had the objectives that the board had formally agreed to give direction to the staff to develop the draft regs, which he, I think, circulated around. There's some aspects of 65 that define who is eligible to get marijuana. That to me certainly seems statute, right? Setting the parameters by which the board and department or whichever agency have the ability to regulate different types of THC by delivery mechanism or granting of that authority seems statute. The different levels of what happens when, that probably seems a little bit more regulatory to me. That's going to be based more about expertise of the department's staff and whatnot. I think that obviously where you use the money and where the money goes and that sort of stuff, typically that's statute. You know, One of my objections to 65 was I thought it was inappropriate for the Board of Health to have the ability to decide where it affect tax revenue, how it gets spent without legislative appropriation. That doesn't seem appropriate to me in our system of government. And that's clearly something that should be in statute. I don't know if that kind of gives a broad sense of this. The 2.5 ounces, I would lump the 2.5 ounces in with the THC stuff and give broad discretion to the department and board to do that. The delivery mechanism, that's a policy decision that's, I think if Dr. Dobbs made his opinion clear on that point about smoking and vaping, and I know he has the support of the board on that. I don't know if there's any specific area, Senator Blunt, my senator, by the way, so I don't know if we're one of the ones that made a mistake. I made it. It's we
just on 65.
Just to see.
No, that's what I'm looking at. We don't want to overreach and do things as legislature that are best left to the doctors and the board. And I think that's just something that's a balancing act we'll have to figure out as we go through. But no, I appreciate your comments. Thank you, Mr.
Thank you. I'm sorry, Bryce.
Thank you. One question. Did y'all have, in your discussions and your deliberation, did y'all discuss about law enforcement and how that was going to be affected? And Dr. Dobbs a couple times mentioned, I guess not penalizing the folks criminally if we're doing this. So did y'all have discussions? And if you did, what was your conclusion?
Well, some of that was directed to us by 65. I think one of the first clauses in there is effectively gives criminal and civil immunity to any agent, employee, officer, owner, whatever. So that was in 65. And as we all know, we were working off of 65 as our guidepost, right? I think that we were, and Chris and Dr. Dobbs, Chris Jones and Dr. Dobbs, they may have spoken to this, or they could at some other time. The seed to sale technology and the tracking systems that we were going through the process, or they were going through of acquiring and obtaining, was there to try to at least address one of those goals that we laid out on trying to prevent diversion and to make it as easy as possible for law enforcement. The department had an advisory committee that was trying to help inform some of those things, that had some representatives from law enforcement on it, that most of which was going through that seed to sale tracking system. Thomas, if there's anything else I'm missing there, speak up. And I do know that in the conversations over the last 2 years, and talking a lot with DAs and sheriffs and police chiefs, et cetera, and that was a major concern of theirs. I mean, the medical marijuana looks an awful lot like marijuana in that it is. And if you, there's that concern about how do you differentiate. We had things like
if they stop somebody and they got marijuana in their car, I mean, there's no identifying mark that tells if it's illegal or if it's medical.
Right. And so
that puts them in a predicament.
It's challenging. I mean, that's the feedback we certainly got for them. It's challenging. I mean, we tried to address that somewhat with the caregiver aspect. The 65 contemplates a caregiver. I'm in a nursing home, or I'm too sick or whatever. I need somebody to go to the dispensary to obtain the product. Well, okay, how many people can they really, be serving at one time? Things like that were addressed in the regs as an attempt to try to address some of those concerns.
Senator Horn.
Thank you, Mr. Chairman. Jim, you spoke about the tension between the medical aspect of the program versus the business aspect of the program. So I'm going to ask you a question similar to the one I asked Dr. Dobbs. Has the State Board of Health reached acceptance that it might be the most appropriate administrator of a medical marijuana program in Mississippi?
Acceptance. That's a tough word, Senator Horn. We are the board is a policymaking board. We take the directives of the legislature in the case of the constitutional amendment directives of people, and we go forth and we do the best we can with whatever parameters we have. I mean, I don't want to say that it's not our job to tell you what to do or not do. I think that Dr. Dobbs said it well, and I'm not sure that I can add much more to it, that there's certain things that the department does and does well with regard to trying to promote the public health and protect the public health, especially as the vulnerable populations that Dr. Dobbs identified, those under age 65, under 25, excuse me, pregnant women, et cetera, that I think that there's certainly, if y'all do put some sort of marijuana program in place, I think that there's certainly a role for the Department of Health in that regard.
Okay, let me ask it another way. Given the trial by fire that the department has gone through, are you comfortable that the department can run this program?
I'm very comfortable in Dr. Dobbs and Chris and the staff of the department. Absolutely. I mean, I think that they, but at the same time, I'm not so sure how comfortable they would be in terms of taxation collection and agriculture monitoring. And there's certain aspects of 65. And I think Ken brought it up at the beginning.
Yeah, I mean, if we gave you the authority to deal with ITS, to deal with Department of Revenue, to deal with Ag and Commerce, and to farm out various responsibilities, you feel comfortable going forward?
I would say that to echo Dr. Dobbs, I don't want this to be forgotten. You know, the legislation that passed in the last session, I believe, was conditioned on 65 being constitutional in terms of interagency transfers and things of that nature. And this program, I think, is very, 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 very tough to implement if you don't have the full flexibility to work between agencies.
Thank you. Thank you, Mr. Chairman.
Thank you. Thank you, Mr. Perry. Some of you may remember Mr. Perry as the policy director for Governor Barber. I remember Mr. Perry as a newborn infant at the Neshoba County Fair some years ago. His mother was a very good friend of mine, and she remarked that this was the easiest fair she'd had in years. It appears that it was her duty to prepare huge quantities of food and beverage for practically the entire state of Mississippi, and then spend a week delivering said food and beverage to the entire state of Mississippi when they stopped by the cabin one by one. I've never been involved in an undertaking like that, and I've never given birth either. But according to Mr. Perry's mother, giving birth was the easier of the two of those undertakings. Yes, there was the story when they came to visit Mr. Perry for Parents Weekend, and there was I in the dorm room. I have had these boards prepared with the text of the constitutional amendment. I believe it to be the case the people of Mississippi very much support some form of medical marijuana. I'm not sure I believe that each voter was up late the night before the election reading through all 9 of these sections and provisions of the Constitution, proposed constitutional amendment. But be that as it is whatever, we're here, and I think we need to pass some sort of medical marijuana legislation. In doing so, I'd say one more time, it seems to me the first step ought to be to determine what sort of marijuana policy do we want to have. Do you want to have recreational marijuana? Do you want to have medical marijuana, which is easily used for recreational purposes? Do you want to have a tightly drawn medical marijuana statute? What decisions do we want to make about how and where that marijuana is distributed? All of those regulatory issues. To me, that is the first step. The issues about taxation and the issues about the economics of growing this and people who are investing in it, those are important issues. But to my way of thinking, those are secondary issues. And the first thing we should do is decide on what sort of marijuana policy we want to have, and then secondly, deal with the other issues. We have here two final matters. One is former Governor Ronnie Musgrove is here with us. And there's a motion to rise and report. If you're in favor of the motion to rise and report, please cheer.